Good morning. My name is Rachel Jankowitz. I am an associate professor at the University of Pennsylvania and the Penn Medicine Abramson Cancer Center. I'd like to thank the meeting organizers for the opportunity to serve as a discussant for the Spotlight poster session focused on invasive lobular carcinoma, or ILC. I have no disclosures. The 4 posters that I will be reviewing are listed on this slide. The first abstract is 476, portraying tumor evolution of lobular breast cancer through phylogenetic analysis. Dr. Fimarelli and colleagues used patient samples to examine metastatic dissemination events and underlying tumor heterogeneity over time. They looked at 38 patients with metastatic ILC, 6 of whom had de novo metastatic disease. In total, they had 99 paired tissue samples from primary tumors and metastases, together with clinicopathologic data. They performed low coverage whole genome sequencing on the samples to infer somatic copy number aberrations. They then performed phylogenetic reconstruction and distance analyses. Late divergence was observed in 48% of patients, with the metastasis closely related to a single primary sample. Early divergence was observed in 52% of patients, with the metastasis clustering separately from the primary sample. Metastases clustering together in a single branch suggested that they were seeded from a common metastatic precursor. Alterations in driver genes were mostly shared between the primary and metastatic samples, indicating early events in tumor evolution. Metastasis private alterations were also observed in specific driver genes, such as FGFR2. In 30% of patients, the genetic distance from primary to metastasis was negative, representing fewer copy number aberrations in the metastasis compared to the primary sample, which was a possible indicator of decelerated tumor progression. These patients were mainly de novo metastatic, had metastasis often to liver and bone, and most had copy number aberrations accumulated in the trunk of the tree, shown in green. The authors concluded that different metastatic dissemination events take place in ILC. Negative genetic distances correlated with de novo metastatic disease and metastatic site, suggesting different evolutionary patterns and underlying biology are associated with metastatic behavior. These findings shed light on how ILC tumors evolve through time and warrant further validation. The second poster is abstract 1703. Does chemotherapy benefit patients with hormone receptor positive, HER2 negative invasive lobular breast cancer? Dr. Yagi and colleagues from Cleveland Clinic used the National Registry database to compare outcomes of patients with early stage ILC treated with various systemic therapy regimens. They grouped more than 17,000 patients with early stage ILC into 4 treatment cohorts. Most patients, 60%, were treated with endocrine therapy, depicted in green, and 25% were treated with chemoendocrine therapy in yellow. Very few patients were treated with surgery alone or chemotherapy alone, and thus the analysis was focused on these 2 main cohorts, both of which had similar 5-year overall survival of about 90%. The patients treated with chemoendocrine therapy were significantly younger in age, had higher stage, more positive nodes, and received more radiation therapy compared to the endocrine therapy group. After adjustment for such characteristics in a multivariate survival analysis, in the 2 groups, there was no differences in 5-year overall survival observed between the endocrine therapy and chemoendocrine therapy cohorts, which together totaled more than 15,000 patients. Their next multivariate survival analysis incorporated Oncotype DX scores, which were available for roughly 1/3 of the patients in the 2 cohorts of interest. Propensity score matching was performed. The model included age, lobular histology, stage, comorbidity score, radiation therapy, insurance, and Oncotype DX scores with exact match of overall stage. This yielded 3,003 patient pairs. 5-year overall survival still remains similar between the 2 groups in the matched sample. Finally, overall survival at 5 years was similar between the endocrine therapy and chemoendocrine therapy groups amongst patients with Oncotype DX scores less than 26, and as shown in this graph, for the 485 patients with an Oncotype DX score greater than or equal to 26. How do we place these findings in context of existing data about chemotherapy for patients with early stage ILC? Concern for chemotherapy efficacy in ILC has arisen given lower rates of successful breast conservation and PCR after preoperative chemotherapy in ILC compared to patients with IDC. But these may not be the best prognostic indicators in ILC. Chemotherapy could still provide benefit in treating micrometastatic disease, and it is thus important to try to identify subsets of patients with ILC that can benefit from chemotherapy. And we can do that by using existing data and prognostic tools. This slide shows a 2021 meta-analysis of over 38,000 patients with early stage ILC, showing similar findings to the current poster abstract, that adjuvant chemotherapy was not associated with improved overall survival in ILC. Disease-free survival was unable to be analyzed, as few of the included trials reported this endpoint. You can see, however, that one trial reported by Dr. Donanoville and colleagues was an outlier, showing significant chemotherapy benefit in ILC. Taking a look at that study, improvements in both disease-free survival and overall survival were seen in patients with early stage ILC treated with chemotherapy compared to those treated without it. And the beneficial effect was even more pronounced after propensity score matching on the right. They next showed that chemotherapy significantly improved outcome in patients with high-risk scores by a clinical risk stratification system shown here, but not in those with low-risk scores. Molecular signatures also offer prognostic and predictive information in some cases for patients with early stage hormone receptor positive HER2 negative breast cancer, but sub-analyses confirming predictive value in ILC have been less conclusive. The 70 gene signature, or MammaPrint, has demonstrated independent prognostic value in lymph node negative ILC. Dr. Metzger and colleagues presented a sub-analysis of the MINDAC trial data at EBCC in 2020, showing that 16% of ILC cancers will be classified as high risk by the 70 gene signature. Additionally, 38% of ILCs classified as high risk clinically will be reclassified by the signature as low genomic risk. And the 70 gene signature performs similarly for IDC and ILC, supporting its prognostic value for ILC. Observational studies of the 21 gene recurrence score, or Oncotype DX, have shown that it classifies few patients, generally less than 8% of ILC tumors, as high risk. Most are classified as either low or intermediate risk. The recurrence score was also found to have prognostic value in an analysis of over 7,000 patients with ILC, with high-risk scores being associated with increased mortality. But chemotherapy treatment was not associated with benefit for patients with high and intermediate risk scores. A second, smaller study in ILC patients in the West German Plan B trial failed to confirm its prognostic or predictive value in ILC, but had very few high-risk patients included. Existing assays were not developed on ILC histology, but a LABCS assay has been developed on ILC and appears to provide better outcome stratification. It thus has potential to be clinically relevant and is certainly worthy of further validation, and we look forward to that data. The next abstract is 2043. Bromodomain and extraterminal motif BET inhibitors are a rational therapeutic choice for the treatment of invasive lobular carcinoma, presented by Dr. Ward and colleagues. As background, bromodomain and BET proteins are key drivers of oncogenesis in cancers. BET inhibitors prevent interaction between BET proteins and acetylated histones and transcription factors. Prior work from the same lab showed that some ILC cell lines were sensitive to BET inhibition while others were resistant. Treatment increased dependence on anti-apoptotic proteins and induction of FGFR1. Targeting FGFR1 in combination with a BET inhibitor was highly effective in ILC models, and high BRD3 mRNA was associated with poor survival, specifically in ILC. Dr. Ward and colleagues thus aimed to target the BRD family using BET inhibitors. They selected a panel of 9 BET inhibitors to study in ILC cell lines. 2D IC50 analysis selected 5 inhibitors, which induced the highest cell death. Of the 5, 3D survival analysis showed mivabressib or MIVI and JQ1 achieved the highest cell death. These 2 drugs were thus chosen for further assessment. They then carried out RNA sequencing on the 2 ILC cell lines, MM134 and SUMP44, to assess differential expression after treatment with the 2 inhibitors. You can see in the bar graph and volcano plots on the right that MIVI demonstrated a significantly higher effect on differential gene expression than JQ1, both up and down. The volcano plots illustrate upregulation to the right and downregulation to the left. Color indicates significant change and gray insignificance. The different colors are coded with the upset plot below. The red rectangle on the upset plot highlights pathways that were commonly upregulated by both BET inhibitors in both cell lines, which were generally pathways involved in apoptosis and growth inhibitions. The blue rectangle on the upset plot highlights pathways commonly downregulated by both BET inhibitors in both cell lines, which were pathways involved in DNA binding, cellular division, or metabolic processes. Next, they used genome enhancer pipeline to find master regulators from the differentially expressed gene lists. They identified 298 master regulators using sequencing data, and one of the highest ranking MTRs was FGFR3, which was compelling based on their previous work highlighting significance of this pathway. They then filtered the MTR lists through their BRD3 knockout data, which yielded 37 MTRs affected by BRD3 expression. The authors looked at expression of the 37 MTRs in both cell lines by each of the 2 treatment drugs, their expression in the BRD knockout condition, and the direction of the expression up or down. The final area on the left shows the expression of the MTRs in the initial sequencing data by cell line and treatment condition. Of interest, when BRD3 is knocked down, there is a decrease in aurora kinase A, which is involved in the cell cycle and indicated as an oncogene in many cancers, and also an increase in the tumor suppressor TP53. The last slide shows encouraging in vivo data in ILC cell line derived xenograft models, illustrating synergistic anti-tumor effect of the BET inhibitor JQ1 in combination with tamoxifen compared to tamoxifen alone. This is seen in the right-hand graph. The same effect was not observed with fulvestrant plus JQ1. The last abstract is 1775, presented by Dr. Robert Hills and colleagues. Effectiveness of aromatase inhibitors versus tamoxifen in lobular compared to ductal carcinoma. Individual patient data meta-analysis of 9,328 women with central histopathology and 7,654 women with ECADHEREN status. As background, we know that the EBC-TCG meta-analysis showed that aromatase inhibitors are more effective than tamoxifen as endocrine therapy for postmenopausal patients with early-stage breast cancer. Some reports have suggested greater benefit for aromatase inhibitors versus tamoxifen in lobular versus ductal carcinomas. For example, in 2012, Dr. Metzger presented this data showing increased relative effectiveness of letrozole compared to tamoxifen in patients with ILC in comparison to IADC in a retrospective analysis of the Big 198 trial. The authors of the current abstract sought to validate these findings in a larger data set of 3 randomized trials and to investigate the relationship between pathology and immunohistochemistry for E-cadherin status. Data was collected from 3 randomized controlled trials, the Big 198, ATAC, and TEAM trials, including central pathology review and E-cadherin status. Local pathology was available in 2 trials. Pathology was compared with E-cadherin by cross-tabulation, prognosis, and interaction with treatment, or analyzed with standard EBC-TCG methodology. This table illustrates data by trial together with sensitivity and specificity of E-cadherin for detecting lobular carcinoma compared to central pathology. You can see that the agreement between methods was poor when looking at the detection of lobular carcinoma, with rates of lobular cancer being higher when assessed by central pathology than by E-cadherin status. This figure shows time to any recurrence by central pathology and E-cadherin status in an analysis stratified for trial, age, nodal status, and grade. As you can see, outcome was worse for those with lobular cancers, either defined by central pathology and or by E-cadherin negativity. This figure shows an overall benefit on recurrence of AIs versus tamoxifen in keeping with the overall results of the EBC-TCG meta-analysis previously published. However, there's no evidence of any interaction between treatment and ductal versus lobular carcinoma measured either by central pathology or E-cadherin on either endpoint. Given that there was inconsistency in classifying patients as lobular, an analysis was then performed looking at a 4-way classification using both approaches. Again, there was no significant evidence of heterogeneity of effect. In conclusion, this work shows that there is lack of agreement between methods and pathologists on what constitutes lobular carcinoma. Patients with ILCs appeared to have worse prognosis, irrespective of method of diagnosis, after adjustment for confounding factors. There was no evidence of any interaction between treatment and lobular versus ductal histology, however determined. We can't rule out smaller quantitative differences, but this analysis has not confirmed the Big 198 findings, and there is no evidence that ductal versus lobular histology is a predictive marker. In conclusion, we've seen excellent work from the investigators in this session that contributes to our understanding of invasive lobular carcinoma. Uniform diagnostic criteria for ILC are needed, especially given data showing inferior outcomes for patients with ILC compared to IDC. Understanding different metastatic dissemination events occurring over time in ILC can inform future therapeutic strategies. Meta-analysis showed that adjuvant chemotherapy was not associated with improved overall survival for patients with early stage hormone receptor positive ILC, but it's still important to try to consider potential chemotherapy benefit in patient subsets. Clinical pathological parameters and molecular assays can help inform decisions about chemotherapy for individual patients. Next, BET inhibitors seem to show promise as a therapeutic strategy for ILC in laboratory models. Meta-analysis findings do not indicate that lobular versus ductal histology is a predictive marker for hormonal therapy. It is encouraging to see existing trials in both the early stage and advanced setting for ILC, and we eagerly await their data to inform design of future studies for patients with ILC. I would like to thank my mentors, patients and their families, Komen grant funding, and TBCRC investigators who have nearly completed enrollment on TBCRC 037, our trial for patients with ILC, and the tireless efforts of LBCA to advocate for ILC awareness and research. Thank you very much.